Without any question, interventional radiology plays a very important role in the treatment of unresectable HCC through locoregional treatments like transarterial chemoembolization and 190 radioembolization. It's very important to realize, especially in the treatment of intermediate stage HCC, that TACE cannot be the treatment for all patients. The treatment stage is rather heterogeneous, and only a minor proportion of patients will benefit from those treatments. For the treatment of advanced stage HCC, unresectable HCC, the gold standard remains sorafenib treatment. There were results published recently comparing radioembolization to sorafenib, showing no significant difference between those treatments. Since there is a significant proportion of patients who cannot tolerate sorafenib treatment, there will be still room for a 190 radioembolization with aspects of tolerability and efficacy to treat HCCs.
I think interventional radiologists need to know that we now, in addition to first-line systemic treatment with sorafenib, we also have effective second-line treatment with regorafenib, and that overall we now, even with drug therapy, can prolong significantly the survival of our patients to even beyond 26 months after switching to systemic therapy. And then, of course, it's always important for interventional radiologists to remember that they are a very important part of the multidisciplinary team. They're important in deciding which interventional treatment should be used. Then, of course, they're applying the interventional treatment, so they're very important with regards to apply, for example, TACE in the most appropriate way, in a way that's actually not detrimental to the liver health of the patients. Then they're important in making decisions in terms of changing the treatment strategy, and that could also include, for example, stage migration, stopping treatment with TACE and moving on to systemic therapy.
Systemic treatments have not been part of the tools for treat hepatocellular carcinoma since the beginning. They only came into the field about 10 years ago, because before that time, before the time of targeted agents, the conventional chemotherapy was not able to provide any benefit on survival of these patients, because they often suffer from cirrhosis as well, together with hepatocellular carcinoma. After the successful study with sorafenib, there were the hope that many other agents would have entered the field, but this was not the case for almost 10 years. And only recently, the resource trial was able to demonstrate a further prolongation of survival in patients who were tolerating sorafenib but were progressors under this treatment. There is no single specialist who has the role to decide what to give to the patients, but it is more and more important to sit down in multidisciplinary team meetings to work together with the interventional radiologists, the pathologists, the oncologists, the surgeon, and tailor the treatment according to the precise condition of the patients, the liver function, and keeping in mind that some of these patients under systemic treatment do not only have gain in survival, but some of them may even achieve complete response. Very few, but even those progressing under sorafenib have shown potential complete response under regorafenib. So this is an opportunity that we should not refrain from offering to our patients. But clearly this is complementary with all other treatments, and the individual strategy has to be decided together. So I think there's a new era for our patients and for our teamwork managing as physicians this disease.